is going to be Dr. Mona Abdel Aziz. She's the Director of Public Health at
Warrington Borough Council.
Manchester.
Warrington Borough Council.
Warrington Borough Council. She's going to tell us about the role of the diaspora and partners in embedding health in our policies.
Bismillah, walhamdulillah, wassalatu wassalamu ala rasulillah. Good afternoon, everyone, and thank you very much for the opportunity to talk to you. And what I'm going to touch on is the role of diaspora in the wider sense, our responsibility for health. And the morning session actually focused on our role of diaspora in our host countries. I'm going to talk about our role of diaspora in our original locations. And while I will give some examples from the Sudan, it will be relevant to other countries as well. Actually, health in all policies is a global movement. It has been declared in Helsinki and led by the WHO that health is the domain of everyone. It's not just the domain of medical field, nor is it the domain of just the health sector. But I want to also link my talk a little bit to what we heard from Professor Moise, because what we try to do in public health is we try to segment, and we try to segment populations. And I would really appreciate personalized medicine in enabling us to segment our interventions to the individual level, which is brilliant for public health. So hopefully we get there. And I also want to link it in terms of technology and innovation and development. And we have been used to innovation and development originating in the West. But more recently, we have seen disruptive technologies originate in our developing world. I have just one example, for example, in terms of the mobile phone technology that has very deep penetration into across the world. And we are finding that even through digital IT, that maybe Asian continent, African continent have some really disruptive technologies that the whole world can learn from. So from a health perspective, the mobile phone has been very good news for Africa, because through the mobile phone, you can connect with the rest of the world, and you can interact with health professionals, and you can set up whole health information systems. So this is just one example of what I mean by health in all policies. So in my presentation, I'm going to touch very quickly on a few principles. These principles are well known, and they are not to be challenged. But I will move on to some assumptions that I have personally made. You may not agree with my assumptions. I will try and put in some examples as to why I believe that this assumption may be correct and may hold. I'm also going to give some examples of good practice. I will use example from Sudan, but I will also talk about system leadership, and Mayada opened her talk, so ended her talk by talking about adaptive leadership. And I will finish by recommendations for all of us. For all of us in the room, for all of us who are listening from outside the room, recommendations for all diaspora, not just in the health sector, and for partners, local partners in our home communities all around the world. So one of my principles is there's always two sides to a story. So you could see a young lady here, or you could see an old woman. Actually, these two, you could see them both. But sometimes when we hold one viewpoint, we can't see the other side of the story. That's when we become dogmatic, that we have our own version of the truth. And one example of that is how we perceive health and illness. You can consider health is just being the absence of illness, but the World Health Organization has advocated for many years, as we have all, that health is a composite sense of well-being, and it is not just the absence of disease. Another principle is that we are interconnected, and we will have heard of the 6 degrees of separation, the fact that I can connect with anyone else in the world in 6 steps. So if I can connect with you, your connection with someone else, you can get me to anywhere in the world. So we can reach out to our local communities through the 6 steps of degrees of separation. And this is also about how we intervene. So our interventions have also got 6 degrees of separation. So this interconnectedness of the world is a global movement, and we heard earlier about the global citizen. So again, for me, this is a principle that we can use to our advantage. And because we are connected, it doesn't matter which discipline we come from. So the health has many determinants. Some of them are social and environmental, as Mayada has said. Others are behavioral and personal, as Professor Moise has said. But in our different sectors, whether we come from the business economy sector, or from housing, or from agriculture, or from economy, everything that we do has an impact. And that impact can be one that we can identify and we can agree beforehand, but there are also unintended consequences. So instead of moving from A to B in 6 degrees of separation, we can find ourselves at some random spots on this network unintentionally. So this, again, is a principle about the fact that we are interconnected, that health has wider determinants. Our interventions have sometimes intended consequences, which is great, but very many times we have the side effects. And they're not just side effects of drugs, but there are side effects of very big policy decisions that we can see worldwide. And then I move on to the health sector. The health sector has tried to simplify the way we think about the health system. And Mayad has already told us about the system building blocks from leadership, financing, workforce, and so on. The intended consequence is that we improve health, that we are responsive, that we improve efficiency through quality, safety, access, and coverage. So this is the intended direction of travel. Using the example from the Sudan, we sometimes find some unintended consequences. So logically, if we were to put in all of the good health system blocks and we were to improve efficiency, and we will progress, therefore, to improve coverage of health insurance, or we will improve health and well-being, but there is a little bit of an unintended consequence that we have to deal with. The other health determinants, like clean water, education, housing, and so on. So the influence of other sectors can lead us to some unintended final destinations. And these intended and unintended consequences can be complex, volatile, ambiguous, uncertain. And I think that is just a matter of fact. So these are statements of fact. We need to work together to make sure that we are very clear about where we want to get to with our endpoints. So I'm going to move on to my assumptions. As diaspora, we should consider ourselves a part of the problem and a part of the solution. How are we part of the problem and part of the solution? We are the brain drain. But then we also have this knowledge and skills and connections to be able to contribute to the solutions back home. An example of this is in my home country. Every state, we looked at the numbers of health workers in those states, and we looked at maternal deaths. And we saw that the states with the lowest number of health providers had the highest number of maternal deaths, and vice versa. So this shows us that the inequitable distribution of the health workforce leads to adverse health outcomes. But since then, that research was in 2012, since then, in 2013, there has been a second wave of really intense migration. It hasn't just been in the health sector. Education and all of the other sectors have witnessed that same wave of migration. And at that point in time, when we went to ask Sudanese health professionals, 86% of them intended to migrate. 86% of them have migrated, actually. And the projections over the next few years is that it becomes less and less optimistic. Why is that? That is because the economy has had an unintended consequence on health. A second assumption, role of our partners. We have to be working together. The program is that together the world is better. So together for health means that we have to work together on environment, economy, transport, information, so all of us in this room and everyone who is outside of the room. As an example, I'm going to use the health insurance in the Sudan. The challenges that they face currently is that some of them are within the health system. It's about medicines and new technologies and stuff. But there are wider system issues of inflation, subsidies, and the price of the dollar, availability, and migration of health professionals. I already spoke about the impact of mobile health in my introduction. So this is just another example of how together we can develop new solutions that are disruptive. So there are now new mobile health solutions and new mobile money solutions. What does mobile money have to do with health? Well, of course, if you can pay your health workers remotely and you can have transactions that are sort of remote transactions, then that is definitely good for health. So my third assumption is that there are solutions for health in all policies that can improve health for everyone. Sometimes the solutions are put forward by others. So if someone in your network contacts you and you're not ready for it, remember the 6 degrees of separation. We should embrace these solutions, whether they come from the media, from the public, or from our worst critics, actually our best critics. I know that I'm running out of time, so this is just one example of looking at the intended and unintended consequences of the refinery business, petroleum refinery in Sudan. This again is an example of good practice. And so the way that was assessed was a procedure which involved all stakeholders in a health impact assessment. Similarly to health impact assessments of the petroleum industry, we have health inequality assessments that can be done alongside it. And there are also examples of the value of business to health. So as experts, we should accept that there are solutions that are grown elsewhere, that they are more likely to bed in and have local ownership. I notice that time is up, so I will not dwell on any of these. I think that there already is good practice in health in all policies. The global health strategy in the Sudan was co-developed by a range of stakeholders. A health in all policies initiative is taking place in the Sudan now, building on at least 5 years of a National Health Sector Coordination Council. But that only meets twice a year. What we need is day-to-day working collectively to deliver on a roadmap. So my recommendations, and these are my last slides, that as the diaspora and we are part of the solution, we should manage our returnships. Maybe we could have an initiative through us or through ourselves where we are always there in the Sudan, where I'm only there for a month and then Mead is there for the following month, and 12 people can on a rota. It's for the third month. It's public health now. Just maintaining a presence there, a continuous presence, not necessarily by the same people, but at the same time that we would have someone from agriculture, economy, IT, business, health, all there at the same time. We can continue to do what we've been doing for the last 15 years, remote advice, strategic visioning, and so on. But I think the biggest thing we can do is that we can support the voice of others. That when the other is saying something that we don't agree with, they have a grain of truth. We should let go of my resource and move to our common interests. And I will end here. Jazakumullah khair. Alhamdulillah.